Thank you very much, Rahul. Can we reduce the volume a little bit? It's okay. Yeah. It's great to be here in this very formidable room. And over lunch, I was chatting with some of the faculty, and it became very clear that my talk would have been more appropriate in the gravitational wave meeting. At least I could get by the stuff I'm going to present without too much questioning, maybe. But I think everything which I wanted to say which I wanted to cover has been said. So what I spent the last few minutes is to try to change the focus of my talk into how the government collects data, both in how it did it traditionally and how that traditional route is changing. Now, this itself has many problems in talking to this set of people with the faculty over here, because there are many kinds of data collection, and many of the people here are intimately involved in that. So I'm very likely to be wrong in almost all the details. But also, I think the specifics of what happens, each one of them and you will have different opinions. So the idea is not so much to give you an answer about what is being done and what is happening, but more to stimulate discussion on the kinds of things which are happening. So I'll address two components. One is, how do national surveys, how have they been collecting data, and how that is going on now. And then how a relatively recent National Digital Health Mission, which was launched, I think, sometime in June or so, 2020, what are its contours and how that is likely to have an impact. Now, you would have heard and you will hear a lot about various kinds of technologies which generate data directly from individuals and from the ecosystem, as well as technologies such as sequencing technologies and its data analysis, which have been transformative. And all of that, of course, will have to come into a data framework for access and sharing. So that's what I wanted to say before I started. Then there's the other point which I wanted to say, which I needed to change my talk a bit. I assumed wrongly that this discussion was sort of a free-flowing, closed discussion, and I could say anything and get away with it. But now I understand it's on YouTube and the whole world hopefully no one will see it, but can in principle listen to what we're talking about. So I'd like to give a caveat that many of the things which I'm saying could well be incorrect, and they should be taken more as topics for discussion rather than hard statements. Okay. So with that, let's get started. So I'm going to talk about public good for using health data and how research can help that. And as I said, the key issues are, how does one access such data, and how is that analyzed, and how it's distilled. And the short point which I'd like to make on this slide is that we have institutions in the country for many, many decades, which are involved in all of this, but all of them have two major challenges going forward in today's world, in that we started off by making institutions so that we have one of each kind. And clearly that doesn't make sense for a country this size. So one national institute of this, one national institute of that. Those institutions either have to be hugely expanded and empowered to deal with today's world, or we need many of that kind talking to each other. Similarly, for the analysis of data, in the public sphere also, there are many institutions. Notable amongst them are the Indian Statistical Institutes. They have a terrific capability in analyzing such data and distilling it for decision making. Those institutions, great as they are, still are, have moved to a position where they train people in these kinds of tools in general, but are not actively linked at the hip as they used to be with the decision-making structure. So the result of that is you have high quality capability in both kinds of institutions I mentioned, but they're not sufficiently connected to action. That leads in a feedback to the health system, as it were, government, citizens, everyone else complaining that the institutions are not doing enough, and the institutions complaining that they're not getting enough flexible ways of looking at data so that they can't. And there's validity in both these kinds of views. Now, let's go to health data collection. Now, while I was looking through this, I happened to be studying a newspaper op-ed, which came sometime in, I think, 2020, April or so, by a community medicine person, a clinician from All India Institute of Medical Sciences, Delhi. His name is Anant Krishnan. And I'd like to present a summary of that op-ed, again, not in the least an endorsement of what is written there, but as an example of how that addresses some key points, peppered with his opinion, which you may or may not agree, or I may or may not agree. So let me go through that quickly, and that tells you how public health data in its most impactful form is collected in India today. And as I said, there are many people here, Gagandeep, Shinjini, others who would know about this in great detail. And if there are any questions, I'll just point you to them. So this is the title of that piece, Needed a Public Health Data Architecture for India. And what Anant Krishnan says is that the principle, and this is of course the fact, that the principal way of collecting data has been the National Family Health Survey. It collects at a fine granularity at a district level, and it addresses topics such as fertility, child mortality, contraceptive practices, so on and so forth, and also the utilization and quality of selected services. And this is an organization, this survey is run by an organization which is part of the health ministry. And I think that organization, I'll come to that. And this survey has been expanded consistently over the years since it has been there. I think it was started in 1992 or 1996 to include a lot of non-communicable diseases. And really anyone who wants any survey done and who can get it on board to the this survey, the NHFS will jump on and do this. So it's become a place where all sorts of mixed bag of data collection demands are being put on this survey. So Anand Krishnan argues that the household question in the fourth survey had 74 questions, and the women's questionnaire had 93 pages, and with 1,139 questions, and the men's questionnaire was 38 pages with 843 questions. And the fifth survey was even longer, and given the hard reality of getting people on the ground to go through and collecting data in a rigorous manner, there are obvious challenges to being able to get this done well. Now, the costs of this are actually relatively modest for the scale, and they are borne by multiple organizations, the Ministry of Health, and also other international partners, USAID, the department, the DFID from the UK, the BMGF, and the UNICEF. So since 1992, one would have expected to see a substantial expansion and a detailing and a change in the structure so that it can deal with all this, but that has not yet happened. Now, the NFHS is coordinated by an institution in Mumbai, the International Institute for Population Sciences, and it's a health ministry institution. And I had the good fortune to go and visit that place a couple of years ago. It is a situation where the institution actually runs this program with multiple agencies. So its own core staff doesn't run it. And in many ways, it epitomizes the state of many of these critically important institutions in our country. Given that there is little or no lateral entry of scientific managers into such organizations at multiple stages of their careers and requirements of the institute, pretty much everyone in the institute, with some notable exceptions, have grown with the institute. And the result is that they are extraordinarily well-trained and knowledgeable about what specific programs they have to do, but they are ill-equipped to deal with a rapidly changing world. This is a problem, I mean, apart from challenges of infrastructure and facilities and so on, this is a challenge in those scientific organizations where lateral entry and exit is not easy to do. So there have been many points about the entrenched nature of the agencies which have made it a life to survive on these surveys. And they too suffer from this, that typically it's a very good idea to choose agencies which would be very good and able to manage the changing scientific parameters, but yet many of them are entrenched in the ways they do this survey, and they have done it in a very valuable manner. They continue to do those valuable components, but the world is also changing. So issues have been raised on the quality of the agencies and the workers. That's what Anand Krishnan says. Now, the survey has added on there are other surveys too. The NHS is not the only survey. Now, the Health Ministry has conducted the National Mental Health Survey, the Global Adult Tobacco Survey, the Alcohol Survey, and comprehensive, sorry for the paragraph change, there's a National Nutrition Survey and many others. And the Indian Council for Medical Research has also conducted many surveys, a most recent one being one on the prevalence of diabetes, for example. So there are many of these other surveys. And the implementation of the other surveys have also been a challenge, and they have gone on to implementation, that is, who conducts the survey and gets it done. They're typically, again, outsourced. The Health Ministry and the ICMR and others either do it themselves or quite often outsource it to their national institutions or partner institutions. So that's the way by which this data is collected. But given all of this, the alignment of data from all these different surveys and actually analyzing the data from the major survey itself becomes a huge and humongous task, which is complicated by the quality of the data going in, because the size and the dramatic changes in the way people live, the size of the population, the way people live have changed. So structuring the surveys at a district level resolution becomes a different kind of challenge also, which needs to be done. So what Anand Krishnan proposes, and again, I'd like to stress that this is what he proposes, and I'm not saying this is right or wrong, is to have only a few national surveys and focusing the NFHS on reproductive and child health, on a behavioral survey and a nutritional biological survey. These are the three components which they need to focus on. And this, I mean, he says these are only three, but they are actually can be broken down to many subunits. There's a huge range over there. And then they need to, in terms of the nature of the survey, he says we need to see which are the ways by which they can be better conducted and choose those the best for each of these. Now, of course, there are other agencies within the government which collect data on the mortality and also on the quality of the health system. Those are separate from this, the health system functioning. So the alignment of surveys is difficult. Okay, I'm repeating that. Sorry, these are slides. Am I going back? Oh yeah, of course, I'm going back. No wonder it looks like I'm repeating. Yeah. Now, separate from this op-ed which summarized the health surveys, the Niti Aayog, which is a think to action tank, which replaced the Planning Commission, had a Vision 2035 in partnership with the University of Manitoba. And that focused on public health surveillance in India. And this is something which I should not go more deeply into, but it's worth reading. Because in many ways, it proposes a new kind of structure and mechanism, which more or less or doesn't address in depth what I talked about earlier. It is as if that you need to, given the size and the nature of the change taking place, you need a completely different approach, is potentially the argument, but it's worth reading the entire report. And there, if you see, there is one arrow coming here on strengthened research, and that is something which it pays obeisance to about how research could come from this, and that's actually an important component. But it looks at the foundation about how public, private, central government, and all other organizations, through their health facilities, can look at a hospital management information system, medical records, and go into a platform, a common national platform, which has got a national and state level leadership and governance on top of that. And all the statistics, plant and animal disease statistics, environment indicators are supposed to come in. Also, all sorts of other health information, the national programs, occupational health services, and so on. So this is a sort of a flow chart for a proposed public health surveillance system of what it will look like in 2035. I'm not aware of how this went into action or not, but the Niti Aayog has another document which is an overview, and this is again something which is worth reading, on the National Digital Health Mission. And this is something which I was talking to Leelavati, and she pointed out that this hadn't entered the conversation here, so I thought I'd put that in. And this National Digital Health Initiative is somewhat related to this, but has got many, many distinct features. And this was discussed intensely in 2020, and then was before 2020, 2019, 2018, it had already started in a test way. 2019, the broad structure was discussed, and in 2020, it was announced by the Prime Minister that it will be started in some union territories as a test run. And now I was looking at the website of the Ayushman Bharat Digital Health Mission, and it is being rolled out in multiple states, or has been rolled out. And you can go to this site and look at what the current status is. But I should say that the Niti Aayog report is much more easily accessible at one point, and this is more a dispersed site, though it's useful. So what is this mission? Again, like the previous report I talked about, it has connections to e-pharmacies, personal health records, family registries, a DigiDoctor, telemedicine, health ID card, and all of this is supposed to work to integrate patient information. So it's very patient-centric as opposed to the family health survey, which deals with completely different or other complementary matters in great detail. So let me go through what the structure of this is. So you've all heard about the digital public infrastructure. Then you've heard about the UPI infrastructure for financial transactions. And the idea was that the NDHM will be a digital health infrastructure, which will have a unique health ID, unique ID for doctors, portable, secure end-to-end health records, and real-time actionable results. So this is, I mean, remember, health is a state subject, and the central government can put on certain kinds of broad principles. And so this needs to be a combination, but this is a rather big and transformative idea, and it'll be interesting to see how this goes on. Again, it's not to give an opinion on it, but it's good to see how this rolls out and how it links with the other surveys in terms of health data collection and how researchers can analyze that and feed back into decisions. So what is the blueprint of that? Again, it has at the foundation a cross-domain generic Jan Dhan insurance, Aadhaar and mobile interface, electronic registries, personal health records, and claims and data analytics, data anonymization, and health analytics. And this is something which is, again, very important and meaningful for research. So how this has unraveled is something which all of us should be watching. It has components of preventive care, diagnostics, and telemedicine. And it's got a marketplace of various players coming in to put their products in for all of this, and both government and private apps and the diverse user experience. In other words, it is in many ways, where is that side on the UPI? It's sort of like the UPI in many, many ways, but it has a more centralized information structure. Okay, so the proposal, this is again from a report from 2020, and the proposal was that personal health records, patients will be able to teleconsult with anyone. The rules and regulations for teleconsultation have changed. That was changed during the pandemic, so it's in principle possible for teleconsultation now, much more or possible legally in a manner which was not possible earlier. So that's an important practice already there. And insurers will be able to cover OPD visits and not just IPD, as cost of processing health claims, they suggest, will come down rather significantly because it's all digitized. So this factor about monitoring for outbreaks and mapping, again, that needs to be analyzed, how that will be done and how the data will be analyzed. This area, the second one, is a topic for this meeting substantially. There are components which overlap with the first. There is a very strong presence of the Ministry of IT and large teams which were involved in developing the Aadhaar and the UPI system, were and are involved in this. So there's great back-end support over here, and the feedback from the health ministry at the earlier stages was that seems to be dominant, and the health ministry's inputs were not sufficient, and there was a lot of pulling and pushing about where the digital health mission should be housed, separately from the National Health Authority or within but a slight distance. And then it came about that it is under the National Health Authority. So it's completely under the health ministry and under whom the National Health. And there will be also research feeding into this matter. The idea also is that it brings digital records available, and personal health records will be taken up. And it will link, and this is again a big challenge. Poshan Abhiyan is run by the Ministry of Women and Child. There are other ministries or other departments, such as the National Health Mission. And, the challenge is going to be not just within the health ministry, integrating data exchange and analysis, but between multiple ministries, not to mention state governments. So how all of this will be enabled is to be seen. And I think the challenges of digital infrastructure, but also of stuff flowing in that infrastructure. So the idea was that the national insurance setup really needs this digital health mission for it to be effective. Otherwise, having insurance available to people through PMJ is not useful unless their health consultation and records can be digitized and accessed in multiple ways. So the idea was that it enables continuum care through personal health records. Doctor registries will allow e-claims. Each health facility will have a unique ID so that when people go, there's less of them going to places which are not certified. And finally, health claims platform will be used. So this then just gives you a relative flow chart of how this happens. And here really the state and central data warehouses and the anonymization of data is going to be very important for that to feed back into the research system. So in 2020, the idea was it can leverage existing organizations, be ready within a year, and save a substantial budget because it partnered with the Ministry of IT rather than seeking its own budget to develop it. And that took off really well. And this was something which, even before the National Digital Health Mission took off in 2020, all of this was already happening. And now the challenges going forward. So I was reading up on what the situation is at this stage with the digital health mission, and it has a CEO and it's fully rolling in terms of its expenditure and its programs and so on. After the early, modest rollout in a few union territories, so it'll scale up. But what is the level of data acquisition and organization and feedback needs to be looked at more carefully. I've not been able to see that at a more granular level. So the collection of data by these two methods is something which I thought will be valuable for us to talk about. Now, in terms of data analysis, I would suggest that two kinds of places one can look at. One, the UK has opened, I think Saravanan will know when, a few years ago, 2020 or thereabouts, a UK health research information organization. So basically, it collects all the information from multiple areas like this and makes it accessible to registered users, researchers within the UK and outside with such specific conditions. And that's something worth looking at in detail about how functional it is, how it is managed or not to integrate UK health research information and feedback. The other country I looked at, which was again remarkably well done, and it's a challenge for India, of course, because the scale is very different, is Sweden. Sweden not only collects all this information, analyzes and feeds back, but it allows its citizens individually to upload information into these registries and sites after they register and give their names and so on. So you can directly put your information, not through all this flowchart, but directly at any level you want, and you can also access at any level you want. So I don't know, again, how well that is working. So these are the two examples are worth studying. It's worth looking at the data, going in and being used in the National Digital Health Mission, because there must be an enormous value of data. Unlike the health surveys, which are complementary and different, address a different topic, these are more, the data is more real time, as it were, as well as more patient-oriented. And there it's a much more complicated, diverse set of information which comes in. So when both are, well-oiled, it's possible to get an overall total picture. Well, let me end by saying that from our point of view, as researchers, there's a very big challenge. I think it's absolutely fantastic that you have this kind of a workshop and it brings everyone together. But the question is, what can we do in terms of developing collection of such data and using it? And that's going to be a very long haul in our very complex and very large system. But as someone said, if it's a long haul, the good time to start is now. And the question is, how does one actually do that? Now, to do that requires three kinds of components coming together. One is the data component, the AI, the computer science, the ML components, people who are dedicated to this sector broadly. But keep in mind that the kinds of challenges I've talked about are exactly the same when you're dealing with the consequences of climate change and extreme weather and so on. Except there, the access to high resolution data through remote sensing has changed that field dramatically. That change has taken place also in India. Till 3 years ago or 4 years ago, getting remote sensing data in India was excruciatingly difficult. The space sector rules have changed. The remote sensing rules have changed. The drone policy a new drone policy has come, and the remote mapping rules have changed completely. So now it's possible for anyone, and the machinery has to be oiled by use, to get government data and data from anywhere else in the world, and companies here can actually set up their own ways of collecting data in those areas. And therefore, in multiple aspects of remote sensing, the community has access to data independent of the few government agencies which were driving that in a manner which didn't sort of stimulate the ecosystem to do that. That was for remote sensing. Is it possible for these kinds of ventures to have non-government players yet for public good, to come in and be involved in this data collection, much of which is available in the public space or can be available, both in a manner which uses state machinery and state data collection enterprises, but also collects data in independent ways and surrogate markers for what is happening in various situations in terms of disease prevalence or diagnostics or people going to clinics for diabetes or cardiovascular disease or and so on and so forth. So are those data collectible independent by those kinds of tools, analogous but distinct from what's happening in remote sensing? So those two components will address in some way the data collection problem. But the bigger problem comes from its analysis. If you look at the best data analysis organizations in the world, they have extraordinarily talented people, and all of you fall into that category, but they're also in a community where there are extraordinary interactions academically with a whole range of different expertise, and the resources to run such organizations, which are significant, I mean, they're actually large, are also available. So those are two big challenges we have, building the community of researchers who are in this, as well as raising the resources. Typically, and this was seen during the pandemic, many really talented researchers in areas distinct from public health moved on and did a terrific job analyzing data and providing suggestions, but they were and still are a handful. Our public epidemiology and data analysis institutions are hamstrung in multiple ways, as I mentioned earlier. And resources for both kinds of work are relatively modest. So how can one create structures in our context, in the Indian context, which address these big requirements of resources, intellectual collaboration, and high quality of thought in a manner which it can be done more frugally? Now, there are ways by which those things can be done. There are arguments that the huge expenditure on these kinds of things in the West, a significant fraction of that is, due to other major overhead issues, and those are not here. But those are all rhetorical advantages which we must actually try and translate into action. But the fact remains that unless we have a situation soon, and soon meaning we should start soon, where both in terms of surveys and in terms of individual health records, if you don't have a way of collecting and analyzing the data efficiently, starting from state levels or district levels, but going on nationally, we're not going to have a mechanism for large-scale research, analysis, and feedback, not only here, but also to elsewhere in the world. Thank you very much.
Thank you very much, Vijay. And this was kind of complimentary without repeating a lot of ground that has already been covered, I think. So there's a lot of space for questions. Yes.
Can you also introduce yourself?
Yeah, my name is Tarun. I am a technical associate at IISER. So my question, the short question is basically, why would a person participate in a survey? That is the short question. And also, of course, there are some surveys, as you mentioned, there are so many questions right there, like possibly in hundreds of questions. So why will a person, what is the incentive for a person to participate in a survey and ask, basically give correct answers? Right. No, I can explain it because...
Yeah, I agree. I mean, the second part is a very, very big challenge. Yeah. I mean, it's a problem in all, direct interaction surveys that people tend to look at you and try to give you the answer which you want, and not necessarily the honest answer. There are tricks in surveys to go past that and deal with it. But whether the people conducting these surveys are doing that or not, I mean, they're trained to do that. They must be doing it in many ways. These surveys are reputed to be very good. So that'll happen. About why people participate or don't participate, I don't think it's legal to give any incentives. You can't give incentives, right? But the government surveys don't give incentives. Yeah. So it's a difficult task over there. But it's pretty impressive to see, surveys are statistically powered, they're well done, and, they get people to respond to them. So I wouldn't dismiss that aspect. Yeah.
I understand. The thing is, I believe that surveys are incredibly, first of all, very difficult to design as well as to conduct and collect responses. It's extremely hard. But like coming from some, like, let us say, I'm speaking from academic institutions point of view. So I have participated in course feedback forms, and oftentimes we see this question like, okay, was the instructor able to answer your questions? And it just puts me off. I'm like,
I think that's an important point. The questions have to be framed correctly and not.
Yeah. So my question is always like, did people even ask questions? So is this question even relevant? So
Yeah, these are, very well standardized and very deeply researched. The surveys themselves have been researched for their effectiveness, and many of these issues have been addressed. So I wouldn't take those aspects as, not being addressed at all. But my problem with the surveys is that, these were formulated at a time when our population was about a fifth of what it is now. And the timelines required, the surveys take years, and there's, a gap between one survey to another. It was a much less pressing time in terms of the need for such data. Today's fast-paced world and a large number of people and all sorts of other complications being identifiable requires, in my opinion, a dramatic change in the way these surveys are affected without changing the principal purpose behind them. And how one can do that is interesting and important.
Who's next? So I have a question about, this has come up a lot over here, but, the entire data infrastructure argument that you were ending with, and in particular, harmonization of, in terms of health data, a lot of hospitals already have in-house CHRs, and we heard about that from some people last week. And they were already talking about how can, for example, Shankar Nethralaya talk to Aravind Eye Hospital and pool their data sets and so on. And this comes up a lot. So is this ND National Digital Mission coming up with standards and ontologies and so on, or using international ones such that data going forward can be harmonized and can be sort of maybe manually or automatically harmonized going backwards also?
That need is obvious, and the challenge to have these interactions are also obvious. The question is, how does one do that? And the analogy would be to the, unified payment interface, where there are multiple kinds of providers dealing with their detailed financial transactions are not known to the common layer, but an overall understanding of financial transactions at a very fine granularity are immediately available. Now, would that happen here? And if so, how is the question? But, one of the points and all of us must approach these big things with much skepticism. But it's very impressive how some of them have scaled up in a manner which many thought wouldn't scale. Someone's laptop hit the ground. Yeah, so scaling digitally has proved feasible in many contexts. Whether it's feasible here or not, I don't know. Where it's likely to work is in healthcare delivery. By the way, the questions often raised are, it's all digital, how will you deal with the last mile? Many people are not digital, and so on and so forth. So those parameters, again, have been tested out in multiple other components by having what N. Chandrasekharan of Tata Sons called Bridgital, having humans bridging the digital to the last mile. And that's been done on a large scale. So those issues can be addressed, but whether that will, the use of an access of healthcare facilities and collection of that information will result in a way by which you can get research data remains to be seen. Now, last point on that, this is not going to magically happen. People keep asking me more so now than earlier about what does the government think about X or Y or Z. And I think that's like what you said, it's a wrongly posed question, right? It's not that the government magically thinks up something. There's a long and complex process which distills a decision, and that involves multiple people, multiple times. And what decision is taken, one component is all the consultancies and what you push. It's also other components which are not tangible and which one doesn't know, the context at the time and various other parameters. But leave those aside. Unless one formally takes up a need for this kind of a mechanism for being able to feed research inputs into this and get information out to feed into research, that cycle, unless one formally takes it up, it's not going to happen by chance. And you can formally take it up.
Vijay, this is a question which is related to the pandemic when you set up the Arogya Setu. And I remember. So just want to understand that that was a very important initiative. It was data collection and then use of data for public good. What was the success of that eventually?
Yeah. So those kinds of interventions which took place in Singapore, Korea substantially, and in India, they were relevant at a particular time during the pandemic when, the prevalence was ramping up and potential prevention by identifying contacts was a feasible option, right? And that's basically has two components. One, identifying not only your contacts, but being able to identify those who were your contacts a few days earlier and being able to identify the contacts of those contacts, right? Now, this you can do digitally, and that exercise was carried on independent of whether there's a pandemic or not. Independent about what you know about whether someone was positive or not. In other words, a kind of a digital immunization saying that, look, this person, this is the way by which you're interacting, and, one shouldn't. So the veracity of that model could be tested digitally. That said, then this was rolled out. Now, this had another component. This was for smartphones. It had another component for, the other kinds of phones, the old type touch phones, which allowed you to see where those contacts, depending on their mobile number, where they were positioned across cell towers. And what a group at IIT Madras and others did was to analyze all of this data and look at, combine that with prevalence in a district, and they could warn other districts nearby and other places nearby. Anurag Agarwal needs to be admitted. Someone can do that? Should I do it? I don't think I have the authority. Yeah, okay, can you do that? Yeah. For once. Just kidding. So that was very useful. That was a practical example. Now, the point was, can this be more generally used? As one thought was that this could be used as a general interface for all diseases, for all surveillance in due course. But, there's a combination of reasons. One is use by people. It requires voluntary use on scale. That doesn't happen much. The government machinery doesn't work as intensely as on these kinds of things when there's no pandemic. There are other initiatives which are lateral and going on, which are there. So, yeah, so it was something.
Fear of data security or their personal details going into something like this, which would be a deterrent moving forward with these kind of programs.
These are all trade-offs. It depends on what your what privacy you lose and what other benefits you get. It's both a decision at an individual level and at a population level, at a group level. So it's a trade-off. I mean, there are theoretically ways by which you can opt out of many of these things, but as we've known for the last 30 years, I mean, do you possess a digital phone? Do you have a credit card? Do you travel? You know, all of that information is, you know, less and less private at different ways. Now, how much does it add on to that or remove that? It's a question which it's a context-dependent answer. And the security part also, you know, how secure is this? I mean, we know, I was listening to a really nice talk on cybersecurity some time back. And this professor was saying how theoretically, 100% cybersecurity, she said, was not feasible. You know, one can, that's from a purely theoretical computer science perspective. Now, from a practical point of view, you can have different levels of security, but that again is a challenge. I mean, is a lock on your front door security or not? And to what extent, you know? And where would you use it and where is it pointless?
Yeah, no, I mean, one thing is that there are things that one can do with the private sector, but things like the census, which is already now delayed, really has to be done by the government. And unless there's commitment on that.
The NFHS survey is again something which has to be done by the government. Something like the census has to be done by the government. And as this op-ed pointed out, there may be many concerns about the way the NFHS is, but that's A, what we have, and B, in many ways, those surveys have been critically important. So this is a general challenge with everything else also. How does one move into a better system while continuing to get the benefits of a previous one? And this is true for that challenge of, you know, tying your shoelaces while you're running is a big challenge.
Yeah, no, I guess the point I wanted to come with it, all of us are trying to extrapolate from the 2011 census in some way. The Niti Aayog has tried multiple ways of doing it. It seems to be really it seems to be a really hard problem to figure out exactly what the numbers are, state-wise, district-wise. And in a sense, that affects all our ability to understand any models of public health. But that's the sort of second point I wanted to make was that I think this came to me when I was asked a very simple question: how many districts there are in India? If you look at multiple government websites, all government, you get numbers that range from 620, 630, 640, 645, 652. And I saw a number recently on a slide that's 678. I don't know where that came from. Just this simple number, which would be very basic to any form of governance, is not even consistent or even a single number across every government site that you can think of. Right? I mean, I think this sort of hints at something a little deeper, that we should worry more about these very elemental things.
That is true.
Our attitudes should change in a sense today.
That's such kind of serious errors are sadly very common across, you know, not only government agencies, but outside government and institutionally. The difficulty in giving hard data about what's already available is a challenge. But that's more, I think, operational challenge rather than a conceptual.
So let's thank Vijay again for, and you can continue the discussion over tea, and we'll